Good morning. I'm not used to wearing earbuds, so this feels different. But I hope everyone is having a wonderful morning. I know that as far as I'm concerned, I keep expecting some sort of normal routine with homeschooling, and instead it feels like chaos. Like every single. So this morning, my son got into all sorts of stuff he's not supposed to. So that was fun. But thank you for joining us. Dr. Patricia Mclelland is with us.
Good morning.
Good morning. Happy Monday.
Happy Monday to you too. I do want you to see, this is my home office. I also have an orchid hospital so that you know.
Yay.
My husband just lit my candle, and
Aww.
my dog Ryan wants to hear it. Oh, he's right there. Ryan, look.
Oh, you gotta bring the phone, I think, down a little further.
Okay, Ryan, right there.
Hi, Ryan.
He's a golden retriever who is highly supportive of women.
Yes. Yes.
So we got our trifecta here. How are you this morning?
I'm good. I was saying that Michael got into some cabinets he wasn't supposed to get into, and we already did an hour of homeschool this morning. So I was like, I keep expecting things to normalize and be comfortable, but that's okay. We are doing great in the sense that everything.
Yeah, I don't know
what
normal means. I don't know what normal means.
And it is like, wait, what day is it? I don't even know what day it is. So it's Monday.
Well, I am so glad that we are doing this.
Me too.
I think there is so much uncertainty. I don't know what the word normal means anymore. And I want to make sure that women all over, especially pregnant women and new mamas, feel supported and they're getting helpful information, not just the scary information. And this is a time where really the information changes on a daily basis. It really does. And you mentioned that I'm an OBGYN. I've been practicing for 22 years, almost. And I am on the COVID task force for Women's Services for Erlanger Hospital System. And we meet almost every day. We've already met this morning at 7 a.m. And I will also say that my practice is also meeting on a very regular basis. So people are diligently working tirelessly to have the best support system for women.
This is unprecedented. So everyone's trying really hard to make this work for everyone.
It is unprecedented. How hard everybody is working together and able to set aside things that are just in everyday life are important, but not urgent.
Yeah.
So we got a lot of wonderful questions, and I want to jump right in.
Perfect. Thank you, mamas, for sending in those questions.
Thank you so much. I am going to be looking over at my notes because I have all my questions written down. So I want to make sure.
Same thing.
Yes. So remember that healthcare providers are all over the world and the U.S. are trying to figure this out. I have cousins in Holland. I have a friend in Croatia. I have a nephew in South Korea. I communicated with all of them yesterday, and we are all dealing with the same issue. And it is surreal. So what we're trying to figure out is, how do we take care of patients best, maintain standard of care, and avoid exposure. Remember, COVID-19 is only about 3 months old. And so it is amazing how much we know, and it is amazing how much we don't know. So there's a couple things I want to start out with on things we think right now. Monday morning at 9:05, on March 30th, okay? Because when we meet next week, my conversation may be a little bit different. First of all, there is no evidence at this point that babies will get COVID-19 when you are still pregnant. So if you get COVID-19 and you're pregnant, then yes, we need to take care of you. But at this point, it does not appear that the baby will get it. The second thing is that babies do not seem to get it from breast milk. Studies have shown that it is not in breast milk. The greatest risk to the baby is going to be a COVID positive mom in delivery. And so mamas and babies are separated at birth, which of course nobody wants, but also nobody wants a sick baby. So our goals are everybody, we don't want anyone sick. We definitely don't want mamas sick during the labor process, and we want to protect that baby, especially during that newborn phase when they are vulnerable. And a baby with a, go ahead.
I'm saying that makes me so emotional just listening to that, imagining being in that situation. Like delivery is scary and emotional enough, much less having to think through all of that. So thank you.
Yes. One thing that nobody asked me, but I just read a report. I was just finishing reading my daily reports, and there was one of the things that has been the most scary for my patients is the thought of having no labor support, because there are places in the country which are not allowing anyone. And the governor of New York just had a court order requiring hospitals to let women have labor support during labor and delivery, which I think, you know, we still have to maintain standard of care. At this point in the Erlanger health system, labor and delivery is the only place in the hospital system where labor support is allowed, or excuse me, a visitor is allowed, one person. And so, so the goal is to still support mom and protect her. So while we're trying to figure out how to protect women and their babies, we are moving towards more telemedicine visits. The postpartum visit is one of those visits that we especially think mom needs to be protected. And so there are ways to try to figure out how to help mom. And what we are doing in our practice is we are doing Zoom video visits. And we've already started doing that. And my patients have been extremely appreciative. And occasionally we still need for somebody to come in. And so I think that there has to be a substitute. We can't just say, oh, we're not going to see you for your 6-week visit. So I think the Zoom visit, because then you can see somebody, because somebody could say, I'm doing great. And you look at them and their eyes are swollen. It's obvious they've been crying. And I may not know that unless I'm looking at you. So I prefer the Zoom visit. And the
then you can kind of use that as a screen, basically, to be like, something more needs to be done. And then if so, you bring them into the office. Okay. And then, like, I know we mentioned before, if mom has 3 other kids, it might be that she's comfortable coming in for her visit, but she's not comfortable bringing 3 little kids that are going to touch everything, right?
Well, we're not comfortable with that either, because we are trying to protect you or the patient, but we also need to protect the healthcare providers, because it is not helpful for the pregnant women for all the healthcare providers to be out. So at least in our office, the only person that's allowed, that we have a screening process at the front of our office, and the only person that's allowed to enter is the patient.
Yeah, that's wise.
Yeah. So what I'd like to do, if it's okay, is to start through with some of these questions. In relation to COVID-19, is it safer to deliver at Erlanger East versus Erlanger downtown? I referred earlier that I'm on the COVID task force, and I promise you that we are trying to protect every woman every healthcare provider on every campus. And at this point, there is no real recommendation to choose one campus versus the other. Now, we have contingency plans on number of patients that are sick, etc. But at this point, there is no recommendation. The good thing about all the hospital systems is everybody is diligently working on this, and all hospital systems are communicating on a very regular basis to make sure that they're on par with each other. And the websites are updated immediately, basically. And so if there's a question on visitors or anything particular, then definitely check that. And if anybody, my group, GYN, we are updating our web page constantly, and also trying to put reassuring information on there as well. So those are two sites that I think are very helpful to get up-to-date local information. The second question was, should my family self-quarantine around my delivery? Now, probably we are in the phase of increasing the number of cases, and probably that will continue for the next 2 to 3 months. So I would say the wisest thing is to try to self-quarantine. Definitely social distance the 6 feet, but I think it is wise to consider self-quarantine for the 2 weeks before the baby comes home. And that would be everybody in the family. Now that's not always doable, so you have to consider what's going on in real life, but I do think that it's wise to consider that. Another question is, if I'm not seen in the office for my postpartum visit, how can I safely increase my activity? Again, I think that either a phone call or a Zoom visit is extremely wise at that point. In general, though, if you have had an uncomplicated delivery, you're not having pain, and you're not bleeding, then you can slowly increase your activity. I do remind women that I don't want you to go out and run 5 miles the next day. I also try to encourage women on the importance of strength exercises, not just cardio. Jena, what are your thoughts about that combination?
I have a lot of thoughts on that. I know. Think that I think that it's very normal for moms to be like, we're cleared. And sorry, for a second ago, I'm getting some questions through I was trying to answer those. But yes, the automatic assumption is I'm cleared for exercise, right? Is I want to lose this baby weight. And so I'm going to get back into like running or cardio. And I'm a huge advocate. And I did that with my first, actually. I remember like going back in the gym and trying to get back into running. And I think that I would have healed so much better if I had taken the time to take that period. And walking, great, right? Walking, pushing the stroller, excellent. But I think when it comes to high impact activities, your pelvic floor and deep core are not strong enough to support that yet. You just had a baby sitting on your pelvic floor for 9 months, right? You just either had vaginal delivery or C-section. You may or may not have had complications. So it's just, why not treat your body well? And I usually like to recommend deep core strengthening for 8 weeks before you get back into high impact activities, is my thought. So, but yes, strengthening is very important. And I think starting off with light weights and then progressing to heavier things as you feel able. But it's the gentle stuff that people don't think of sometimes as exercise that's really healing.
Yes, and I think those are both excellent points. And if somebody, one of the things that's very valuable about an exam is I can see how weak somebody is, and I can assess, oh, you'll be able to do this on your own, or you really need to see a pelvic floor physical therapist. So, but I do also think that plenty of women can get good guidelines and say, hey, we'll see you back in 2 months instead of tomorrow, and just slowly progressing with strength. And one of the things you made a point about your core, sometimes when we talk about our core, people forget that that also means low back, pelvic floor, and abs.
Yes.
Most
Your
people,
canister.
when they think of, yes. Another question, go ahead.
No, I was just going to say, this is a weird time, right, where women, so there's a lot of online resources for you with deep core strengthening. I know we're trying to put out some free content. We also have our 8-week program. But basically find something that works for you. Just because you're home doesn't mean you can't be helping heal your body. I think there's a lot of great resources online. So
there are. Then another question is, what do I do about pain at my C-section scar or pain at the site of episiotomy or tearing? Bottom line, I think if you're having pain at 6 weeks or bleeding, then you do need to be seen. Now, again, we are in unprecedented times, so a phone call with your provider to clarify what is best. Depending on the number of cases of COVID in the area, my comment may be a little bit different today than it will be in 2 weeks. Because remember, my number one goal right now is to protect you and your baby from getting sick from COVID. And so something that I would normally tell you to come in tomorrow because you're having pain, I might encourage you to wait. But we are trying very hard to ask the right questions so we can help you prioritize what you need.
So, and Dr. Mclelland, with that, so if someone, let's say they're 8 weeks out, and by pain they mean, like for instance, with intercourse, right? Or C-section stuff, it's like when maybe they feel fine walking around, but when they try to exercise, they feel like a pulling pain, or, you know, stuff that maybe isn't quite as severe, but sounds maybe a little bit more like scar tissue. I guess through telehealth, what guidelines would you give for like that? Because I know we talk through people through scar tissue releases and how to help work C-section scars, or even like perineal like massage, like stuff like that. So what guideline would you give in this situation, right, where you can't, or someone may not be able to be seen in person and checked before, like what would you say for that?
So I think for the first 6 weeks, you may have all kinds of symptoms. You may feel tight, you may feel pain, you may feel sore, you may feel pulling, you may feel like everything is falling out. All of those symptoms would be very common for the first 6 weeks. After the first 6 weeks, let's first start off with C-section, then we can talk about perineal repair. With the C-section at 6 weeks, everything's pretty much healed, but the scar will continue to remodel for up to 18 months. And I would like, Jena, for you to answer some of the things that you recommend for scar release at that point.
So I can kind of use my arm here, but and by the way, Dr. Mclelland here has done 3 C-sections on me. So I know a little bit personally about this too, but it is something that amazes me that more people are not told to work on scars. I'm talking any surgery, like any surgery, let's do some scar releases once it's healed, right? Once you're 6 to 8 weeks out, there's no signs of infection, that kind of stuff. So if the scar is here, we have several layers of tissue and muscle, and we want things to move smoothly. So if you move your finger over your arm, you should see how everything kind of moves and glides nicely. So with scars, what can happen is it kind of gets stuck, okay? And because of our muscles and fascia, that can affect things all over, not just here. So we often recommend to come in, and if the scar is this way, you can apply a gentle pressure. I like to put one finger on top of the other and gently move across the scar. So if the scar is side to side, you'd be going up and down, okay? And it should not really hurt. There might be a little pulling, but that's normal. And so if you notice, I'm not just doing superficial on the skin. I'm kind of adding a little bit of depth gently, keeping that depth as I move up and down. And you really only have to do this, depending on the size of the scar, 1 to 3 minutes. Okay, it's not super aggressive. And then if it's your first time doing it, I would definitely wait even 48 hours, see how you're feeling. What I usually tell patients, if you feel a little bit of tenderness when you do it, but afterwards you're like, oh, it kind of feels better. It feels freer. I can breathe better. I don't have that pulling sensation. Great. If you're really sore for 48 hours, then we did too much or you're not ready for it. But kind of going across is one simple way to do that, right? All the way across there. You can also come above or below and either push the skin down kind of into the scar or gently, gently pull away. So all of those are different things that you can do to kind of help work that tissue. And I would recommend that for anyone who's had a C-section, whether you're having symptoms or not personally. Like Dr. Mclelland said, things continue to remodel. I think that we want things to heal moving well is my stance.
And the way a scar heals is it shrinks in that spot. And so that's normal healing. But everything that you just said helps release that and release that pulling and pain.
Yeah, it doesn't mean it won't get smaller. It means it will continue to get smaller as normal, but also move more freely and cause less problems. And that was one of our questions, is asking about C-section incision, if it will shrink. So the answer is yes.
Yes. To follow up on that specific question, the question on will my C-section scar shrink, and was my C-section scar bigger because the baby was breech? There are a number of reasons why somebody may choose a little bit bigger of an incision. One is if it's an emergency, the bigger the incision, the quicker. Another is based on maternal weight. When a mother is smaller, then the incision can be smaller. If there is more tissue between the skin and the uterus, then you have to have a bigger incision in order to get to the baby. Sometimes the position of the baby affects how big the incision is, but it's a judgment call at the time. So those would be some of the reasons why someone might have a little bigger incision. But the nice thing is that they do shrink and they are definitely smaller, even by 6 weeks. But especially as mom loses her pregnancy weight, it continues to shrink. We had a lot of great questions about perineal tears, episiotomies. One question was, how do I prevent tearing? There's two ways. One of them is perineal massage. There's a lot of ways people have described that. One way is 1 or 2 times a day, starting at 34 to 36 weeks, and just pushing on the back of the vagina closest to the rectum, and just kind of doing exactly what you basically did on your arm with the scar.
So you're literally coming in here.
Yeah.
Here. And pressing down and back and kind of through this way, right?
And the tightest area is the hymenal ring. So if you can feel, it almost feels like a band depending on how hard you push, so you can massage that. I do think that that's helpful, but I think what's even more helpful is how we help a woman deliver the baby at the very end. And that's a combination of slowing down the pushing at the very end when you don't want to slow down the pushing. You want that baby out now. But slowing things down at the very end is very beneficial. And the other thing that's very beneficial too is how we are holding your legs and protecting your perineum. So in a way, I'm fine with however somebody wants to push, whatever is most effective. But at the very end, I want to be able to have access to protect the perineum, as well as be able to adjust somebody's legs easily to avoid tearing, or to minimize tearing. And it really does make a big difference. So those would be the two big things that I would recommend. Now, the second one, how we help protect your perineum, that's nothing you're paying attention to. That's not anything you and I are discussing, because you are pushing and I'm adjusting.
Is there a certain position that you feel like has the best chance of decreased tearing that you found in your years of experience?
In my years of experience, it's one is easy access to the perineum, so a woman's bottom at the end of the bed. Two reasons. One is I can protect your perineum, and if the baby gets stuck, I have immediate access to the baby. That's a situation where seconds actually do count. You could miss your window to protect your perineum, but you also need every second if a baby gets stuck. It also depends on how you're holding somebody's legs. The exact angle really does depend on multiple things. And so it's something I'm watching for at the very end, and just even moving the angle of somebody's leg. So it's not something I could tell you, oh, well, if it's at this angle, you're perfectly fine.
Yeah.
Because everybody's a little bit different. But if I have good access, then I can help reduce issues with both babies getting stuck as well as big tears. There were some excellent questions about tearing. One question was, I tore, then I retore, and now it looks like it's healed in multiple directions. And I tore, and now I have pain. What do I do? Both of these situations really need an exam. One question is, should I go to a pelvic floor physical therapist? And I think that what you want to do first is you want to see your provider, and you want to make sure your provider is very comfortable with addressing this, because I have seen patients on referral where their provider was not comfortable dealing with this. And patients were told, oh, this is normal. And then patients kind of follow up and ask additional questions.
Can I interject something real quick?
Please.
I was going to say.
Please.
So, yes, I mean, and that's the thing. We hear from a number of providers all the time. And I have some patients that come to me saying, well, I was told that I'm just going to leak now because I had a baby, or sex might hurt now because I had kids. Like, these are all, the different symptoms. They're like, I have plenty of women who are being told it's normal. Sorry, you're just going to live with it. Part of being a mom. So I want to make sure that you understand that while these things are common issues after having babies, you don't have to live with them necessarily. Like, these are things that can be assessed and treated if you get with people who, like Dr. Mclelland said, are trained and comfortable treating these things, or know solutions for you. So not every physical therapist, even who does postpartum care or OBGYN, is going to be comfortable with these topics. So you want to make sure the people that you're seeking, that this is in their wheelhouse.
Exactly. And, if somebody is leaking for the first week after delivery, I do say, let's just hold tight. At 6 weeks, that's a totally different discussion. And what I recommend is not really a one size fits all. And there are times where I will send somebody to a physical therapist right away. And there's other times where there are some issues that need to be addressed before. So if there's a problem that's causing a lot of pain, that needs to be fixed before we address the pelvic floor. I know my comments are very general, but it's really hard to be super specific without knowing the exact symptoms and doing the exam. And I think you can tell pretty quickly if somebody is comfortable with addressing that. Another question was, what do I do if I have pain with sex? Now, once you're cleared after your 6-week visit, then especially if you're breastfeeding, your vaginal tissue is thinner and drier. And so a lot of women will have some discomfort with intercourse. Using lubricants can help. But if it's the normal discomfort, that really does get better pretty quickly. So if you are not getting better pretty quickly, then you definitely need to be assessed. And that really is also an in-office visit.
Yeah. So basically what you're saying is the first couple times, whether you had C-section or vaginal delivery, the first couple times of intercourse, it's totally normal to expect some pain or discomfort. But by a few times in, you should be able to do it without pain.
Amen.
Yeah.
Amen.
And lubricants. If you didn't need lubricants before, you may need them, especially that first month like the first month that you re-enter.
Especially if you're breastfeeding. Especially if you're breastfeeding.
And I'll go ahead and I'm going to go ahead and add coconut oil and Good Clean Love are my two favorites as far as good for the mama. So
yes. Then this also kind of goes along with Kegel exercises. That was not a specific question, but a lot of times women will be told, do Kegel exercise by. Couple issues. First of all, a lot of women, their pelvic floor is so weak at their 6-week visit that either they cannot engage those pelvic floor muscles or they're doing it incorrectly in a way that'll make their symptoms worse. And so some people, they should do them, they can do them, so go do them. And some women can't do them. And so why waste your time to tell you to go do it? But the third is if you have pain, then a lot of times doing the Kegel exercises are actually going to create more problems. And so it's definitely not a one size fits all. And it's extremely helpful to go see a pelvic floor physical therapist at that point. Right, Jena?
Yeah. Yes, obviously, I believe. Yeah. So we do a lot of evaluations postpartum to assess for all the things, pelvic floor strength. But what I commonly see postpartum is women, like you said, are tight and weak, and their muscles lack coordination. So and so that's where we work on. I mean, even online, the advice we give in our online program, we are very heavy emphasis to like, you need to be able to relax and contract. Just contracting something is not going to help you for most women postpartum because most women have a combination of tightness and weakness.
Correct.
So especially if you have pain, but even if you don't have pain, I think it feels counterintuitive. It's like, but I want to fix my problems. I need to tighten. And it's like, tightening can be helpful, but only if you're actually relaxing and tightening correctly. So just learning more about that. And that's a whole different conversation. So
right. But I guess, and part of me does not want to give a percentage, but in general, I would say the vast majority of women, and it doesn't matter if you were in great shape, you weren't in great shape, I would say the vast majority of women are unable to engage their pelvic floor muscles correctly in order to be beneficial without some sort of guidance. And for some women, it's just what we discuss in the office, and I show them exactly how to do that, and we practice that. But it is rare for me to see a patient where I'm like, whoa, you do it perfectly. We don't even have to discuss it. Another question that we got is, what can my spouse do for me when I am at home? I'm going to expand that question because what I really want to ask is, how do I get the support I need when everyone is supposed to social distance? At the end of pregnancy and for the first 6 weeks postpartum, this really is when you need your village. This is really when you need your village. And we have to attack this question with some ingenuity. And I have discussed this ever since COVID-19 got on the scene. I've been talking about this with my pregnant patients in their third trimester and kind of troubleshooting and figuring out some of the best ways to address this. First of all, you really do want to social distance. You really do want to protect that child. We also know that when we get bored, we often misbehave, whether we are 30 or whether we are 2 or 3. So it's not just the 2 or 3-year-olds that act out. So here's a couple things, and this is with some troubleshooting with some of my patients as well. a lot of spouses are at home. And so reasonably, you guys can pick some shifts. So your spouse can listen out for the baby while you're taking a nap. When I was postpartum and I took a nap, we moved Walker out of range of me hearing. So if I'm still the first ear, my ear ain't sleeping. So he was moved completely
like mom
out of
radar.
range.
You like can't sleep if you hear a noise. Yeah.
No. So so the spouse can do that. The other thing is if you have children that are old enough, they can keep an ear out. You know, mama, go take a nap. Kiddos, you know, my belief is if mom needs a nap or mom needs a babysitter, then TV is okay. So plop
my kids
them
are
in
watching
front of
TV right now.
Good.
I locked the door. Otherwise, they would all be in here right now. So Brian's down there. Don't worry.
I know. But yeah, let your kids watch something, listen out for the baby, and either they're old enough to troubleshoot or they're not old enough and they come get you. The other thing is everybody really needs to do a better job at assessing chores. And everybody should have non-negotiable chores. Little kids can do chores, and they can really do chores. And so there's the benefit of being a team, and there's the benefit of having things get done that normally should not be high on the to-do list. Kids can put their toys away, and they don't necessarily need to get a reward if they haven't. And the other thing is a lot of chores around the house can be delayed. The question is it better to take a nap or fold the clothes? And I'm going to tell you it's better to take that nap. I think the question earlier, do I have my family social distance before delivery? I think it is really wise if you can have somebody in your family, such as your mother, a sister, socially distanced so that they can come help you. I know somebody whose mother came before the due date and is planning to stay until everybody feels comfortable that mom can leave. So things like that, I think, are extremely helpful. I have two patients. They're sisters. They're pregnant at different stages. So what I think is their mom, who I absolutely adore, I think she needs to social distance and she needs to plop at one house, and then when the next one comes along, plop at the another one, with a little bit of sleep in between. The other thing is, I think it's also really wise to be making food ahead of time. That is something that other people can do for you. You can put it on the back step. You can wave from 6 feet away and have some communication. But food, everybody needs food. Everybody doesn't need clean clothes. Everybody doesn't need the floor vacuumed, but everybody needs food. And there's a lot of people who are sitting at home and they're cooking more. So why not make something extra? I think that's a very helpful way to help people. Isolation, that's also hard. You can do what we're doing now. You can do, 3 weeks ago, I'd never heard of Zoom video. Now I'm not a master for sure, but
you do
I
it
can
a lot.
use it. I do it a lot now.
Yeah.
And
now you know how to do
video.
Instagram Live, right?
Yes. Well, I am thankful that we practiced this yesterday because my 14-year-old was able to help me. Now he's in virtual school and can't. The other thing is get outside. Get everybody outside. My older sister and I were talking through different options, and we used to chuckle that my sister-in-law, when her boys were getting quite rowdy, she would send them outside, even if it was raining, to run around the house. And the level of rowdiness dictated the number of times they ran around the house outside. And I don't know about you, but sometimes I feel like I need to be the one running around outside.
Yeah. I've been surprised, and so this isn't even speaking from a medical standpoint, but I've been surprised that as we've been outside, how few people are outside. And to be honest, sometimes when, like, if we go for a family bike ride, I'll get these looks of like, what are you doing? And I'm like, I mean, you can social distance and keep your distance and be very safe and still do something that's very good for you emotionally and physically.
Well, that's interesting because where I live, everybody is out. Now, thank goodness
Really?
we can social distance, but more people are out than I've ever seen, ever. Some of my secret little hiking spots, which nobody ever is, nobody's around, and I'm like, good grief, guys, this is my spot. But one of the things
No, I was just saying, being outside, I think for a new mom especially is really valuable. Like, go for a walk. I had a patient recently that was talking about waking up and having a lot of emotional struggles with all the anxiety and fear and everything. And she was telling me some of her habits that are a little self-destructive in that area. And I was like, can you just, instead of doing that, go take a walk? Like, do something. I know that's harder to do, but can you try to go outside and get some fresh air? And I just think that does wonders for people.
It does. And another thing too is just communicating face to face. Like the other day when you and I were doing this and you were making cookies, that just made me smile. It made me smile. You better save me some, or you better make some for me. But
I gotta make some more. We ate them all.
It just made me smile. And, I think we have to find ways to choose to smile. I think when we think about the postpartum time, there's a couple tasks that nobody can do for you. Nobody can eat for you, sleep for you, shower for you, go to the bathroom, or breastfeed. So I think that you think of those areas before you deliver. Sit down and talk about that with your spouse or your partner. And then that's probably everything you guys decide is probably not going to be the right thing because you haven't introduced the baby yet. So after the baby, you have to readdress that and decide. And I think that nap time needs to be number one, it needs to be on that top 5.
And at night, by the way, yeah, I was just saying at night, one thing that's really helpful if you're trying to get sleep, because like you said, sleep's so important for mental health and for your whole body to heal. And that's obviously the biggest struggle for moms postpartum. So I know one of the things that my family, my mother and my husband did for me is that I nursed. But for instance, I'd nurse and I'd go to bed early and he would stay up that first stretch, right? And if the baby needed anything before that next feeding, he would take care of it. And then he would help again. I'd nurse, I'd go back. He would change the diaper, get the baby back to sleep, and then he'd go to bed. So we kind of like staggered a little bit to help me get some longer stretches of sleep. And then when my mom was in town, other than me needing to nurse the baby, anything the baby needed at night, she helped take care of. And I know not everyone has that, but if you are someone looking to support a new mom, say your daughter is about to have a baby and you have been social distancing or you're a partner of someone about to have a child, have these conversations, because I think that most women take all of that on completely alone. And I think that, yes, your baby's nursing, if your baby's nursing, so yes, you're the only one who can feed that child, but there's much more at night that can be done other than just nursing, in my opinion.
Correct.
So,
and I think, and especially we do have to be mindful that a lot of times the partner or the spouse are working. And so what seems to be the most beneficial that I see for people is somebody the spouse takes the early evening or the early morning shift. So one thing that my husband did for me was I would nurse Walker at 6 a.m. and then at 9, and I would try to push the 9 out a little bit if I could, but he would keep an ear out between 6 and 9, and he would work from home, and it worked out perfectly. So there are definitely times that are reasonable that somebody else can keep an ear out for the baby. And of course, be mindful of the fact that they're probably working as well.
Mm-hmm.
But
they
getting some stretches,
well. Yeah.
getting some stretches at night. And I think initially, sometimes first-time moms want the help at night when they're awake, but you quickly want to move away from both of y'all being awake in the middle of the night.
Yeah, that's fair.
So at 1 a.m., that's when you really need to, of course you'd like to have somebody to talk to, but you need to move away from having somebody up in the middle of the night at the same time, unless it's absolutely necessary, because you both are humans, you both need rest.
So doing shifts maybe, right? So someone taking the late shift or early shift, so you can at least get some pockets of uninterrupted sleep.
And that's different based on breastfeeding or not. So I have yet to meet a man that will sufficiently breastfeed.
I tried to teach Brian, but he just wouldn't give it his all, I think.
What up with him?
I think if he tried harder, he could have done it.
The thing is, I have never met a man who is truly certified in lactation consulting. I had one try to tell me he was, but he never produced a certificate. But the bottom line is that if you're breastfeeding at 1 a.m., you probably ought to be the only one awake. Let them take other shifts. Any additional comments? I just think that the mental health during this phase really is the most important, and you will not have resiliency if you're not mindful of that. And one of the most important things is sleep. So what I tell women is, if you call me and you are postpartum and you are having a hard time, my first question is always going to be, have you been sleeping? And so you might as well try to sleep and then call me. Now, of course, if you call me first, I'm happy to talk to you, but sleep is so vital that really my first thing when somebody's having a hard time emotionally is go sleep. So please, please, please prioritize that. Any additional comments about some of the social isolation?
About social isolation, I don't believe so. So just to kind of wrap back on that, you're saying, yes, obviously we need to, because we need to protect mom and baby, right? But
right, but the emotional component.
Yes.
The emotional component.
Yeah, the emotional component, I think that it'd be really helpful for all of us to remember as we're trying to support moms, is that we really need to be checking in with moms. Even though that you maybe can't even be physically present, that doesn't mean that you can't reach out, and more than just a text, because like you said, texting or even phone calls, if you don't see their face, there could be a lot of women, I think, are hesitant to reach out about some of the emotional distress. It feels wrong. I know a lot of women feel kind of like a failure if they're having a hard time with certain things or things aren't going as planned, which first of all, you're not in any way, shape, or form. But so those of us supporting moms during this period, we need to actually be calling, FaceTiming, Zooming, whatever it is to make that personal face-to-face connection and to check in on them regularly.
I think, and I also think, have the conversation when people want to be called. I would tell you, yes, don't call a new mom before 9 a.m. and don't call them after 8 or 9, but also ask them. I think another thing that people can do too, is people can help get things that they need. If you have somebody, nowadays we have grocery pickups and all this kind of stuff, but there's still times where you might need something emergently. So have some point people who are willing to help you get something emergently. They can put it on your back porch. They can smile at you and wave to you from 6 feet away. But having that kind of backup is also extremely helpful as well.
Yes. Now, Dr. Mclelland, I know we're running short on time. I know one of the questions was, is there a time limit for the scan to be taken?
So there was a question about when's the best time to do the anatomy scan when you're pregnant. Typically that's between 18 and 21 weeks, because that's the time frame where you can see everything the best. That can be delayed I wouldn't do it sooner because you're not going to see everything. But that definitely can be delayed a little bit. The other thing, and to a bigger question about prenatal care, there are visits that you could probably skip, and you can, if you have to do something like a diabetes screen or stuff like that, then you can also put those in appointments. And so depending on how many people get sick with COVID-19, there are going to be times where it is wiser for you to stay at home than for you to come to the office. So I do think, we are working as part of our task force. We are working with the high risk doctors, the maternal fetal medicine doctors, to have some sort of guideline on changing prenatal care visits, at least during the greatest part of the epidemic. And then another question somebody had was IUD follow-up. In the first 2 to 3 months after you have an IUD placed, you can have some mild or minor cramping. You can have some unpredictable bleeding. So if that happens in the first 2 to 3 months, that would be very normal, very expected. So you don't need to be seen for that. If you are having pain or heavy bleeding, then it's definitely worthwhile to have the phone call and decide if you need to be seen in the office. But typically some minor cramping, some unpredictable bleeding, and that goes for whatever IUD you get. If you get the copper IUD, you get the progesterone IUD, such as the Mirena, those first 2 to 3 months, it's normal to have some unpredictable bleeding.
Okay, that's good to know. And then I know there is this question as well. Is there a time limit? Oh, sorry, I just already asked that. How to deal with prolapse in the early postpartum period?
Oh, yeah, that's a good question. I would tell you in the first 4 to 6 weeks, just self-care. Just self-care. I want you to sleep. Let's address this. With prolapse, a couple things. First of all, most likely pelvic floor physical therapy is going to be a wise choice. Another extremely important thing is losing your pregnancy weight. If you think about it this way, every 1 pound of weight you gain increases the pressure by 4 to 5 pounds. So if you have 20 additional pounds, that could be 4 to 5 times that could be an additional 80 to 90 pounds of pressure on your bladder. No bladder tolerates that. And so weight loss is huge as well.
And don't do that with high impact exercise, ladies. Don't go running. Yes. Don't go run and do cardio to lose that weight. So I know from past, and we have a podcast episode with Dr. Mclelland, if you want to listen to that, where we get a little bit more in depth about this stuff. But we're also not suggesting that you cut your calories down to nothing, okay? So this is talking about healthy food choices, feeding your body nutrition, staying away from maybe lots of breads, empty calories, sweets, things that, to be honest, I've nursed 3 kids. You crave those things. I want those things. Yeah. But if you're dealing with heaviness and prolapse, it would be helpful for you to make that choice, not only just to feel like you fit in your jeans again, but to know that's also good for your pelvic floor.
So weight loss, another thing is avoiding constipation. And I think for the first 4 to 6 weeks postpartum, there's an element that your body is going to heal that you don't need to do anything about. So it's after 6 weeks where we really need to start addressing that more. Would you agree?
And yes, absolutely. And like you said, with constipation, with the other advice I give for women with prolapse is learning early on good breathing techniques, kind of reactivating and coordinating your muscles again, because your diaphragm is a part of that canister. So the diaphragm and the pelvic floor should, if they coordinate correctly, copy each other. So as you take deep breaths, that should move the pelvic floor in a certain direction. The point of that being, for instance, if you have to lift up your child's car seat, why not exhale as you lift the car seat? It's going to help engage and take some of the pressure off that pelvic floor. So there are tips and tricks that can help with the pressures in your system, because the reason why you don't want to be constipated is you don't want to be straining and bearing down on that weakened area or that area that's falling or prolapsed. So we'll try to talk more about these subjects in general. So, but just know that our program does go through proper pooping, how not to strain. It goes through lifting techniques. It goes through how to coordinate your breath and pelvic floor. Those are not things we can easily just answer right now, but those are things that we try to equip you with. So all of that stuff would help with prolapse, because really prolapse, I think, is about learning how to best support that system, I think.
Correct.
So I think for today, if we did not get to everything, I know we have a few questions maybe, but we will do our best to discuss those a week from today. Right, Dr. Mclelland? And
correct.
My pelvic floor partner here, Erin, is going to be talking with you next week. But for today, we'll go ahead and wrap up. And I want to say thank you, Dr. Mclelland, for your time and for being on the task force for COVID and for, all these things. I know that you're really trying to help support and keep moms safe and supported during this period. So thank you.
Thank you. What I would like to ask you to do right before we leave is either on your Facebook page or on your Instagram page, if you'll start a conversation about ways to help mom in the postpartum phase, just to give people ideas. Most of the things that I tell women, and I have information that I hand to people, really is based on having a readily available village that you can touch and hug and stuff like that. So we just have to put our thinking caps on and make some adjustments. But if you could start that conversation so that we can add some of those things down. I'm also going to be adding and updating things on our GYN website, but there's only 24 hours in a day. So I can't do everything that I want to do. But we definitely want to support you lovely ladies out there and your families. And today's warm, so I want you all to choose 5 to 10 minutes. And if you're somewhere that it's raining, I don't care. 5 to 10 minutes, get outside.
Amen.
Amen.
I love it. Well, thank you so much. And like I said, we'll put this up. We'll start that discussion, and we will see you guys via this conversation again in a week.
Take care.
Take care.
Bye.
Bye.